It's a pleasure to introduce Dr. Sandeep Dhingra for today's ground rounds. Dr. Dhingra is our 4-year resident. He also has experience working as a psychiatrist in Delhi for a few years, not only with children, but also adult population. The topic that he chose, although controversial and difficult to explain here, is very important due to the implications mainly that this topic has in our daily practice. The topic being religious and spiritual issues in psychiatry. Please welcome Dr. Dhingra.
Thank you. Good morning, everyone. So today's topic is biology of belief, and we're going to talk about religious and spiritual issues in psychiatry. We're going to discuss the neurobiology of religious and spiritual experiences, examples of some normal experiences, and how to differentiate between normal and abnormal spiritual experiences. And then where do we go from here, the future directions. In 1980, when Engel gave this biopsychosocial model in how to evaluate patients, basically we are trying not to behave like these blind men. So these blind men were going on a walk in a forest and they encountered an elephant. And since they couldn't see, the person who was touching the tail thought it was a rope. The person who was touching the trunk thought it was a hose. And the person who was touching the leg thought it was a pole. So they couldn't really get a whole picture of the elephant because they were blind. Similarly, in psychiatry, if I focus only on the biological aspects of psychiatry, or a social worker focuses only on the social work aspects, then actually we are, in a way, blind. So we have to look at all the aspects and look at the patient from all the angles so that we get a full picture. In general, it's a tendency of the mental health professionals to shy away from religion and politics. We are scared, or I don't know what, but we generally avoid these topics. But in the clinic, this is the scan of the page 5 of our intake packet. And if I zoom in, we have a section. Religion, spiritual and cultural factors, describe beliefs, practices, religion and their impact on treatment. I mean, I used to generally just write, the patient believes in God, no hindrance in treatment, that's it. I didn't really know how to expand on that. In DSM-4, we have a category, V62.89, which is religious and spiritual problem. What does it mean? Religious problems, they involve a person's conflicts over the beliefs, practices, rituals, and experiences related to a religious institution. For example, if a person converts to a different religion, he may have some issues. Or if there's an intensification of religious practice. On the other hand, spiritual problems involve distress associated with a person's relationship to a higher power or transcendent force that is not related to a religious organization. For example, loss of faith, separating from a spiritual teacher, and some people also report out-of-body or near-death experiences. They may not be all mentally ill. Know that it's a V code. It doesn't have to be a mental illness. It is just a condition that may be a focus of clinical attention. ACGME and Residency Review Committee also now require programs to instruct residents about the religious and spiritual aspects of patients' lives. But there's something called as a religiosity gap that the APA Task Force on Religion and Psychiatry found. General public and psychiatric patients are more religious than mental health professionals. So the percent of agnostics and atheists in general population is 1 to 5%, whereas among psychiatrists it's up to 50%. So now there's a gap, and if a patient comes to us with these issues and we don't know ourselves how to deal with them, our condition could be something like this. So Why are we discussing it here in a hospital? Why do we have to discuss religion and spirituality in a medical setting? Well, what are the effects of practicing a faith on health? Improvement in depression scores have been seen. There have been decreased suicide attempts in general population and in those with a mental illness, independent of the effects of social supports. And also better immune function, better lipid profile, better BP control. These all have been found in the people who practice a particular faith. But it's not always good. There could be some harms also. For example, some people may have some pseudo-religious ideas leading to hindrance in treatment. Some people have a concept of a punitive God. They may feel that the more they suffer, the better. And some rituals and practices in some religions may actually lead to deliberate self-harm. So we have to know about that. So what are some normal components of religious and spiritual experiences? So if we know normal, only then we can know what's abnormal. So we'll talk about mythological stories in every religion, ritual practices, and some mystical experiences. Every religion has its own mythological stories. So that's the Greek god Poseidon, that's the Hindu god Shiva, and they have their own stories for years associated with them. They all have their rituals. So there's a religious ritual march of the monks in Laos. There's a religious ritual dancing in a tribe in Africa. And apart from mythology and rituals, there's a concept of mystical experiences which has been very confusing in the past, and there have been various definitions of it. So Evelyn Underhill, who was a novelist and a mystic, described it as an uplifting sense of genuine spiritual union with something larger than the self. But our friend Freud thought it was an experience as a result of a regressive infantile neurosis. What happens in these experiences? These experiences may happen during meditations or religious rituals, and they include the way people and experts describe it. There's a state of ecstasy. People perceive themselves as endless. They feel a sense of union with the universe, and they also they have a sense of meaning and purpose in life. But it's not that only mystics and some religious people have these experiences. We can also have these experiences in our daily normal life, and we have had them. So what are those? When you say you lost yourself in a beautiful piece of music, that experience is similar to that. Being swept away by the rousing patriotic speech, or intoxication of romantic love. To understand any experience that includes a spiritual experience, we have to understand the relation between brain and mind. How is it different or similar? Now, if mind is like a wave energy, then brain is like water. A wave energy cannot express itself without the physical presence of water, and water cannot generate a wave without the wave energy. So mind is like a software and brain is a hardware. Similarly, another example, if you want to have any experience, you have to have some hardware for that. So if this is an apple pie, how would you know that this is an apple pie? Well, you have to have vision, you have to have the olfactory system and the taste buds, and they all go up through the nerves in your brain in the association areas, and then you can experience the apple pie as a whole. So to understand any religious or spiritual experience, we have to understand the basic neurophysiology involved in these experiences. So basically, we all know frontal lobe is involved with attention and initiating muscle activity, temporal lobe with language, conceptual thinking, parietal lobe with sensory perception, visuospatial tasks, body orientation, occipital lobe with vision, and we know that left hemisphere is involved with language, computation, logical reasoning, and the right hemisphere of the brain is involved with spatial reasoning, face recognition, and music. We have these association areas in the brain: the attention association area, orientation, verbal conceptual, and visual. Now, what is the function of visual association area? What is it? If this area is destroyed in the brain, it does not impair the capacity of a person to see, but the person is unable to put the visual stimuli into meaningful context of emotion and memory. So some people who use visual imagery during prayers, this area is active. And also some people who use images like crosses or candles, this association area is important for that. Then the next one is orientation association area, defining the self. This is located in the posterior section of the parietal lobe. The left orientation association area creates the spatial sense of self. It tells us where we end and where the rest of the world begins. The orientation association on the right side creates the physical space in which we exist. So if I am standing here, how big is this auditorium and how far do I have to walk to get out of that door? That physical sense of space around us, that's given to us by the right association area. This area is important in altered perceptions of self and space during a spiritual experience. This we're going to discuss in more detail later on. Then the attention association area, which is in the prefrontal cortex. It's involved in focusing attention and emotional regulation. We've all heard that people say that, focus, concentrate when you are meditating. It improves your concentration. It also helps us in emotional regulation, which means that we are better in control of our emotions if we meditate. People say that. So why? Because this area gets activated when we are doing any religious practice. And the activity increases in certain types of meditations. And the verbal conceptual association area is located at the junction of temporal, parietal, and occipital lobes. Every religion has some conceptual aspects. So to understand them, this area is important. Whenever people use any religious language, this is the area responsible for response to that. Apart from these areas, our autonomic nervous system changes, the activity changes when we are involved in any religious or spiritual experience. We know sympathetic is, there's a surge of intense readiness, there's arousal, it expends energy when it gets activated. So in the rhythmic motor activity of rapid religious ritual dancing, for example, this area gets activated, this system gets activated. The parasympathetic sympathetic is opposite of that. It induces relaxation, it conserves energy. So, for example, in slow chanting or in meditative experiences, the body relaxes because of the action of parasympathetic nervous system. People describe these experiences as very emotional, and the limbic system is what is responsible for these emotional responses. It consists of hypothalamus, amygdala, hippocampus. So the hypothalamus is the master controller. It links the autonomic nervous system to the neocortex. And this is associated with the autonomic shifts that occur in spiritual experiences. Amygdala is like a watchdog. It has a surveillance function. So whatever we are perceiving through any sense organ, how emotionally relevant it is for us, amygdala decides that. And the hippocampus is like a diplomat. It regulates these quiescent and arousal reactions. And it also influences thalamus, which actually can block certain sensory inputs during spiritual experiences. So this was about some neurology, but then we have to understand some cognitive functions of the brain also, because every religion requires us to understand it, the concepts. So what are these cognitive operators? Now, one is the holistic operator. It's located in the right parietal area. It allows us to see the world as a whole. For example, these may be different members of the family, father, mother, kids, but the holistic operator tells us this is a family, it's a holistic view. The opposite of that is the reductionistic operator. In the holistic operator, many faiths tell us, look at the big picture, look at you know, the whole picture. That's what it means. And reductionistic operator is the opposite of that. It's located in the left hemisphere. And again, this may be a whole family, but how to reduce that to its component parts? This is the scientific way of thinking. That's how we are trained to think, analyze things, put them into various categories. Then we have something as an abstractive operator. In the interviews, we always ask the patient, what's the similarity between a banana and an apple? And our understanding of the abstract thinking sometimes ends there. But abstract thinking is not just about banana and orange. It's in religious teachings. We've been taught, look at the similarity in diversity. And that's abstract thinking, and the abstractive operator is responsible for that. Then we have a quantitative operator, which means it gives us an estimate of time and distance. How much time is passing? How far do we have to go? If this function is not working in the brain, we won't know. And this area gets numbed or deafferented in certain trance states. So people, when they report that we were having a feeling of timelessness when we were meditating, that's due to the inhibition of this function. The causal operator. That means we have to, we are curious people. We have to find out the cause of whatever is happening around us. So if something happens, there's a loud explosion outside, automatically we'll ask ourselves, what happened? What happened? What's the cause? And that's this operator working. And the same operator is responsible for spiritual quest also. We want to know where we were before we were born and where we will go after we die. And then the binary operator. Life is complicated, and sometimes we don't really know how to make sense of things. So binary operator reduces the most complicated relationships to simple pairs of opposites, like up versus down, left versus right, or before versus after. So we don't really know what's the exact relationship between these two dogs. Maybe the big one is having some existential crisis, and the smaller one is letting him do the catharsis, but we don't know. It's just that on the surface, we know one is big, the other one is small, makes life simple. Whenever we have confusions, we try to separate things into two categories. And we're going to discuss how this operator works in myth making, how mythological stories are created. In a sense, it's a combination of this autonomic nervous system activity, limbic system, and the analytical functions of the brain that leads to any spiritual or religious experience. Now, why do we make myths? We are all doctors or scientists, or we have our logical ways of thinking, but we also believe in heaven and hell. What's the scientific proof of that? We have something called as a cognitive imperative. So how is it defined? It's the irresistible biologically driven need to make sense of things through the cognitive analysis of reality. We have to understand the world. It's automatic. We can't help it. Many years ago, when mythological stories were created, how were they created? So when people thought that everything is not right, we have existential problems, concerns, people are dying, people are getting sick, we are separating from our loved ones, why is it happening? That created a lot of anxiety. So first step was to identify that existential concern. Second, as we said, causal operator. We have to find a cause. When people die, why do they die? What happens to them after death? So causal operator automatically starts working. It tries to just find out what's going on. But then, when it fails, anxiety remains. And the binary operator frames it as a pair of incompatible opposites. Anxiety has to be resolved in whatever way. If the causal operator fails, the binary operator has to kick in. And the mind finds a resolution that alleviates anxiety, even if it's imaginary. So, for example, when thousands of years ago people were confused about death, they didn't know what happens to us after death. So, that anxiety had to be relieved by a story. Okay, there must be another world. So, this world and that world. Causal operator couldn't find it. So, binary operator said, this is the earthly plane. You all go to some other plane when you die. Makes it simple, right? Okay. So, that relieved some anxiety. But then there was another existential concern. Why good people have all the problems and why bad people have fun? How to resolve that? We've been suffering and then we die. What to do? Then the mind said, okay, then if in this life we cannot resolve this crisis, maybe in the next world. So there should be two different worlds, heaven and hell. So all good people go to heaven and all bad people go to hell. So we are even now. So probably that's how the concept of heaven and hell was created. Then we all have rituals in our religions and faiths, which has actually two components. People report subjective feelings of tranquility, ecstasy, and awe during the rituals. It could be a result of altered autonomic activity. But then they also report some unitary states. During any rapid ritual practice or any meditation, there are changes in the autonomic nervous system. It could be arousal, it could be actually quiescence. It activates the hippocampus, and especially the floodgate function of hippocampus, which means that everything that's coming into our brain through our sensory organs, they're not reaching there, they're filtered at some point. For example, inhibition of the orientation association area. During a trance, one may not realize where his body is ending and where the rest of the world is beginning. And he feels one with the universe because the concepts of I and you resolve. So it becomes we because of the softening of the boundaries of the self. Also, apart from this, there's a multisensory stimulation in a ritual. There's music, singing, fragrances, colorful costumes. So it all stimulates hypothalamus and amygdala, leading to positive emotional states. But apart from this, there also have been studies which have actually explored these experiences scientifically. So this study by Newberg and Diakili, they studied 8 Tibetan meditators. What they did was they did a SPECT scan of their brains before the meditation, and then when these meditators went into a trance state and reached their peak experience, they had a thread tied to their fingers. So they pulled the thread, giving a signal to the scientists that, okay, this is the time you could do a second scan and see what's the difference. This is what they found. If you see, so this is the scan at the baseline before the meditation. So the regional cerebral blood flow measured here in these frontal lobes, compare it with the regional cerebral blood flow during the peak experience of a meditation. It's increasing. So they figured out that there's increased prefrontal activity during meditation, which is associated with increased attention and concentration, and that's what is said, that your focus increases when you meditate. That's actually been photographed here. But there's something else also that happens. This is about the frontal. What about the parietal lobes? Again, this is the parietal lobe activity before the meditation in a normal waking state. And if you look here, during the peak experience, it's inhibiting. It's reduced. And if you recall, this is the area, the superior parietal lobe, where the orientation association area is there. That area helps us decide where we end and where the rest of the world begins. What is the difference between you and I? And when this is inhibited, That's what creates the sense of unity or feeling oneself as endless. That's actually been photographed here. There's also something, in the previous experiment, the scientists didn't really induce any changes in the brains themselves. The meditators went to a trance state, they just photographed it. But in this experiment, Dr. Passinger actually created a helmet where they could artificially induce certain experiences. I actually had a video for that, but my laptop didn't work on this setting, so I'm just going to explain it. So it's like a regular motorcycle helmet, but this has been fitted with electrodes. When he studied 900 subjects, when he put on the helmet on their heads and stimulated the temporal lobes, it created something like a micro seizure in the temporal lobes. Not a full-blown temporal lobe epilepsy, but small seizures. They were called temporal lobe transients. And when this happened, the subjects reported strong emotions when this stimulation was going on, dreamlike visions, and also they reported a sense of presence. They said, we had out-of-body experiences. We felt there was someone else present in the room with us. And apparently this was due to mismatched neural activity between right and left temporal lobes. And these TLTs are not always induced just by these kind of apparatus. It could actually be triggered in the brain by anxiety, personal crisis, hypoxia, hypoglycemia, and even fatigue. So if in a very medically ill state, a person is feeling that there's someone else standing next to him, it could be possibly because of these TLTs. Apart from these transient phenomena, even the brain's hardwiring changes over a period of time in people who have these experiences on a regular basis. We know about trauma. A person who undergoes any traumatic experience for a long period of time, for years, the neuroplasticity leads to actual changes in the neuronal synapses in the brain. So that applies to all experiences. That also applies to any religious or spiritual experience. If someone is going through those changes which I just described about the SPECT scan, the frontal and parietal lobe, changes can actually permanently happen even in the regular waking state. What it means is that a person doesn't have to have a better attention and concentration and a feeling of unity with the world only when he is meditating or doing a ritual. It can happen even between those episodes. So that's why we say religious people generally become calm and they are able to regulate their emotions better and they are able to feel one with the universe, even when they're not actually in a trance. This faith factor, apart from these religious or spiritual practices, it also works in a therapeutic empathic relationship. The content of what is discussed in psychotherapy is important, but also a lot of healing takes place because of this faith factor. If a patient is becoming sad in the middle of a session, becoming tearful, so suppose one of this is a therapist and the other one is a patient, there are some neurons firing in the brain of the patient. The therapist sees that affect and also gets the same neurons firing in his brain, and a state of emotional resonance is created in the session. Now, that's another thing, that after this experience, the therapist may regulate his own emotions and come back to his baseline. But that's the basis of empathy. This theory of mirror neurons and emotional resonance also works in a place of worship. Now, why is it important? Because there are lots of areas in the world where we don't have mental health professionals working. What do people do when they get anxious or depressed or upset? They go to their places of worship, and they're anxious, they're worried, they enter a place of worship, and within a few minutes they calm down and relax. Look at their affects. They're all having the same affect of tranquility and peace. And that's a very big support system for people who don't have psychiatrists around them. The picture is a little incomplete. They're all praying, but whom are they worshipping? Yeah, makes more sense now. What are the implications of this in the treatment? We've been discussing all that stuff till now. How do we actually apply this in our clinical setting? So, why is it important to inquire about the spiritual or religious aspects of patients' lives? Well, to improve our treatment planning, to improve therapeutic alliance. If the patient wants to talk about some of this stuff and we have no clue what he's talking about, we cannot create a bond with the patient. To discover any religious reasons for resisting treatment. For example, patients who are Jehovah's Witness may refuse blood transfusions. If we have no clue what Jehovah's Witnesses are, we don't know what to do with this patient. We'll try to evaluate them and we'll try to convince them, and we won't know what's the background, why he's refusing blood transfusion. Suicide assessment. Being a Catholic could be a protective factor against suicide. I've seen so many patients, and you must have seen too, severely depressed. You talk to them, and when you ask about suicide, they say, no, I'm a Catholic. I'm not going to commit suicide. That's against my religion. It could be a protective factor. And to understand patients' moral codes and values, we are doing assessment of personality issues, and we have to know where this patient is coming from. But again, the problem is we don't know how to start a discussion. We know all this background, we know it's important, but how do we actually start it? We could have some indirect methods or some direct methods. Follow up the patient's own use of religious or spiritually laden language. So if a patient comes to you in a session, he says, by the grace of God, I'm going to recover soon. I think I'll recover soon. So you could ask, it seems that God plays an important role in your life. And then let's see where the discussion goes from there. Pursue shifts in emotions that occur related to spiritual themes. A lady is sitting in front of you and saying, well, you know what, last Sunday I couldn't go to the church. And then she becomes tearful, starts crying. If you are scared of talking about these things, you will not pick up that cue. But if you know, okay, this is something important. So you could ask, how important is it for you to go to church? What does it mean to you? And then let's see where it goes from here. Or exploring other clues like clothes or jewelry that the patients wear. A patient always comes with a big cross pendant or always carries a religious book in his hand. We could start a discussion on that. If you have a really good rapport with the patient, you can even ask direct questions. Is religious faith an important part of your life? How has this faith influenced your life? But again, depends on our confidence levels. We don't want to start a discussion and feel clueless after 5 minutes and we wouldn't know where to go. So it depends on how confident we are feeling about this. So if we are not very confident about these issues, maybe we could start with some questioning on existential issues. Well, where do you find the strength to cope? What means most to you at this point in your life? What are you living for? Where do you find love and peace? So Carandale has actually recommended the use of a 5-scale biopsychosocial-spiritual inventory in primary care settings to get a full picture. But are we supposed to start these discussions every time with every patient? No, there are some contraindications. If a patient is frankly psychotic or manic, he already thinks he's God and he's hearing the voice of Jesus. You don't want to explore his deep-seated religious beliefs at this point in time. Maybe at a later point when he gets well or improves, but not at that time. Strong patient resistance. He doesn't want to talk about it. Why do you want to start a discussion on that? Just because we are reading about the spiritual aspects, we don't have to always ask the patient about this. Patient doesn't want to talk about it. Or little relevance to clinical problem. A small child has come to you with nail biting. You cannot start asking questions about his deep religious beliefs. Doesn't make sense at that time. Or if you feel that at some point in time it feels like a violation of boundaries or there's some ethical problems, stop at that time. We can always address it later. We can discuss with the supervisors and later on address those issues. Now, we all are human beings, so we have our own beliefs. So it's possible that our own beliefs may impact this whole interview process. And our beliefs can lead to countertransference. So we have to ask ourselves, if someone is talking about religious and spiritual aspects and we are having rage or anxiety or anger, we have to ask ourselves, why am I having such a strong reaction to this patient? I could be a skeptic. It's possible that I don't believe in God, but that doesn't mean that the patient doesn't believe in God. So is my own skepticism an impediment to the therapeutic process? Or the other way around, if I am too religious and patient doesn't want to talk about this stuff, I don't have to impose this stuff on the patient. So is my personal interest in this area leading me to focus too much on it? The APA Committee on Religion and Psychiatry recommends that psychiatrists should not impose their own religious or anti-religious ideas on their patients. Many times people do that, but that's not right. It all depends on the situation, and you have to know very clearly whether it's in the benefit of the patient or it's just helping you do your own catharsis. And if we see that people are having these experiences, we have to have a differential diagnosis. Again, very simply, patient could be psychotic or manic. It could be a schizotypal personality disorder. He always senses a presence wherever he goes, but he's not frankly psychotic. Patient could be delirious. He's having visions of Jesus after an operation. Temporal lobe epilepsy. Now, this is important to understand. In temporal lobe epilepsy, patients do have hyperreligiosity. In fact, studies have been done where stimuli were given to the people and their emotional impact was measured. The temporal lobe epilepsy patients, they respond very strongly to religious stimuli. If you show them a cross, they'll respond very strongly. Whereas the people who don't have temporal lobe epilepsy, they respond more strongly to sexual stimuli. So that's the difference. But again, the important thing here to understand is that even between seizures, even in the interictal phase, the patient may be hyper-religious. It's not only that during the seizures they become hyper-religious. Dissociative disorders and depression. Sometimes people go through certain phases in their lives where they want solitude. A person, for example, has been diagnosed with liver cancer after many years of history of alcoholism. And now he is not like depressed. He is having normal sleep, he is not suicidal, but he is just going through a phase in life. He wants to be alone for a while. He wants to stop talking to all his alcoholic friends. And he wants to probably find a new circle. And the family members may think, oh my God, I think he's depressed. Doctor, what can you do about it? And we talk to him and he says, no, I'm not depressed. I'm just going through a phase in life. I want to be alone. So that's where this diagnosis has to be ruled out. How to differentiate between psychosis and culturally accepted religious and mystical beliefs and perceptions. Psychosis many times is associated with perplexity. It could be a possibly frightening experience for the patient. Whereas culturally accepted religious belief and perceptions, people report an experience of serenity and wholeness. Psychosis is involuntary. You cannot generate psychosis at will, but these perceptions can be voluntarily generated with these practices. Psychotics are generally socially isolated and dysfunctional, whereas mystics could be very effective members of society. We still have some unanswered questions. How can we more accurately distinguish true spiritual experiences from false perceptions? Because that's where we'll have to decide whether this person is sick or not. Do we have to give medications? Or can we just support him and just wait and watch? How can we objectively measure clinician sensitivity to spiritual dimensions of the patient? This is like a self-assessment. We have to know how sensitive we are towards these patients. And can a healthcare clinician be actually trained in these qualities? We talk about cultural sensitivity. We also have to have this kind of sensitivity. But instruments are being developed for this, but we still are not very close to the solution. And in future, there are some unresolved issues. We have to discuss them, like specific management of conditions under V62.89. What do we actually do in these areas? And then clinician training in spiritual and religious sensitivity. Visiting our old friend, the elephant again. So we talked about the biopsychosocial model. But to get a full picture of what's happening with the patient, is it sufficient to focus only on the biological, psychological, and social aspects? Well, maybe not. To understand the patient completely, we have to follow something called as a biopsychosocial-spiritual model, which includes biological, psychological, social, legal, spiritual, and religious aspects, developmental issues, to get a full picture of what's going on. Now, for many years, so many wars have been fought, and the cause has been religion. But after knowing all this information, we feel how ludicrous it is to engage in war based on religion. So when a person is fighting with another one on some religious issue, what exactly is he trying to say? That the neuronal blip in my left prefrontal cortex is stronger than yours, and so my religion is better than yours? Or maybe the attenuation of regional cerebral blood flow in my right parietal lobe in the SPECT scan is more than yours, so I should get more rights as a citizen? So basically, what I feel and what you would agree to, that the area in the brain that's most active in the brains of religious fanatics is the area associated with rage and aggression, which actually has nothing to do with religion. And that's it. Thank you.